As I've said before, time flies like an arrow, fruit flies like a banana. It's time for another Puscast, this one covering the first 2 weeks of January 2014. As usual, the references are available online, and I don't think I've mentioned this yet, but I have started a new organization. Well, not me, but me and some colleagues over at Science-Based Medicine have started the Society for Science-Based Medicine at sfsbm.org. Feel free to wander over and examine our website and our goals and mission statement. But you haven't come here to listen to me blather on about my non-infectious disease-related projects, even though the world does need more Mark Crislip. You're here to listen about infections. So let's get on to the literature, shall we? The saying is, don't believe everything you think. And it's nice to have information that supports what we think is true. This was a systematic review and meta-analysis that looked at the relationship between antibiotic consumption and antibiotic resistance. And they found a remarkable number of trials, 243, and found that, yes, indeed, there was a strong relationship between antibiotic consumption and antibiotic resistance in the community. This is followed by a similar article I should mention, which falls in the water is wet, fire is hot category. But this article out of Antimicrobial Agents and Chemotherapy looked at appropriateness of antibiotic use in the emergency room for acute respiratory tract infections and found that while inappropriate antibiotic usage was declining in the pediatric population, it hasn't budged in adults. They estimate that for acute respiratory tract infections, that 535 per 1,000 patient visits for acute respiratory tract infections receive inappropriate antibiotics as judged from the guidelines, which is pretty amazing. Combine these two studies, and there are many like the second one, you can see why we are getting into a world of hurt when it comes to antibiotic resistance in bacteria. Use it and lose it. You know, the problem with medicine is that opinions change as data comes in, and sometimes things become more confusing rather than less. I mentioned a couple podcasts back, there was a study in JAMA that demonstrated that quinolones were not associated with retinal detachment. Now, there's another study that shows that it is. This one is slightly different in that evidently there are three kinds of retinal detachment. There's your exudative, your tractional, and your rhegmatogenous. And this study found that there was an association between the use of a quinolone and rhegmatogenous retinal detachment on the basis of a population-based cohort study. They found it was worse with Cipro, which had a much higher risk than levofloxacin, norfloxacin, or ofloxacin. I'll let epidemiologists with better minds than mine let me know which of the two studies is more valid. But for now, given the preponderance of data, would suggest that quinolones are indeed associated with retinal detachments, independent, by the way, of underlying ocular problems, and it would appear to be worse with ciprofloxacin. Not a surprise, there was a meta-analysis that looked at the use of herbal medicines of a variety of types for the use of viral myocarditis. And they found that there was no data in 20 trials involving over 2,000 patients to show any change in mortality in patients treated with herbal medications for their viral myocarditis. There were a variety of secondary endpoints that may have improvement, but as they point out, quote, due to the risk of bias of the included studies, small sample size, and limited number of trials on individual herbs, you have to interpret the results with care. Then they always include the following in these kinds of trials. Further robust trials are needed to explore the use of herbal medicines for viral myocarditis. No, we don't. We need to find out whatever the ingredient is in herbs, if they are efficacious, and see if those can be used in viral myocarditis. There is, to my mind, as much need to try herbs for viral myocarditis as there was, as mentioned in the past, a need for further trials on acupuncture for the treatment of mumps. I think this year has been the second worst influenza season I have yet to experience professionally, the worst being 2009. And there are things trickling in, as always, about influenza in general, although we'll learn in 6 to 9 months why this season was bad. The first concerns the risk for Guillain-Barré in patients with influenza vaccination. This study was done in Europe, where most people received adjuvanted vaccine, which is not used in the United States. And they did not find in their study a significant elevated risk for Guillain-Barré after receiving flu vaccine. And the most they can say is that if it exists, it would be at a rate of more than 3 per million vaccinated, which I'd like to remind people is far less than the incidence of Guillain-Barré from influenza, which, per the Lancet article, is much higher after the disease than after the vaccine. Another study to show that pregnant women who get the vaccine have a decreased chance of having a preterm infant and a decreased chance of having a smaller birth weight baby. Influenza has many adverse effects on pregnancy. Pregnant women are more likely to die. They're more likely to miscarry in the first trimester, 1 in 10 estimated in the 1919 pandemic. They're more likely to have smaller babies. They're more likely to have premature babies. And they're more likely to have stupid babies if you use lifetime earnings as a marker of intelligence. And the vaccine has never been demonstrated to have adverse effects on either the pregnancy or the Of course, the best way to prevent influenza is probably to get vaccinated. The vaccine is not great, 50-50, but it's better than nothing. And why don't healthcare workers get vaccinated? This particular study looked at this issue, and it's always boggled my mind that healthcare workers would not get vaccinated to protect their patients. And it turns out that usually it's from a lack of knowledge about influenza vaccine, which sort of is interesting. I would think if you're a healthcare worker, you would know a lot about the vaccine, but the usual reason that people don't get vaccinated is they are young and they are underinformed about the vaccine. I think this is particularly important for healthcare workers because a recent study demonstrates that immunocompetent patients get much more severe or complicated influenza compared to normal hosts. And as a consequence of being immunocompetent, they are less likely to respond to the vaccine. So those who most need the vaccine are often the ones who are least likely to respond to it. And as healthcare workers, I think it's our moral prerogative, or actually our moral imperative, to be vaccinated to help protect our patients. And just remember that the rapid flu test stinks on ice. Its sensitivity in this study out of Japan was 72.9%, which I think is a gross estimation. The plural of anecdote is anecdotes, not data, but there seems to be a surfeit of patients who have negative upper respiratory rapid tests and PCRs who on bronchoscopy have influenza in the lower airway. I wonder if the virus is drifting away from the current testing modalities. We'll know better again in 6 to 9 months what actually happened in this flu season from a diagnostic and therapeutic perspective. The HIV epidemic started roughly the same time I began my medical career. Remember that association is not causality. The old days, people used to die in 9 months, and it was awful. Now, in an article that was published in PLOS, they estimate that a 20-year-old HIV patient who receives retroviral therapy is expected to have an almost normal life expectancy and to survive into their 70s, which is pretty amazing. There are still differences in sex and race and CD4 counts, but it's amazing how this has gone from a rapidly fatal disease to a chronic illness in just 15, 20 years. An interesting report suggests that men who go to church are diagnosed with their HIV later. And of course, the later you present with your HIV, the less likely you are to have a longer life expectancy. But being a churchgoer does not appear to be a positive factor in getting your HIV diagnosed. I'll avoid the snotty commentary. Interestingly, in Switzerland at least, that drug resistance is usually caused by transmission by treatment-naive people. So that people who have never seen therapy are probably having acquisition of HIV that is resistant to art and then passing it on to others. And really brings home the importance of doing genotyping before instituting antiretroviral therapy in HIV patients. And Harriet Hall likes to refer to it as tooth fairy science, where you apply scientific techniques to fundamentally pseudoscientific or fantasy-based. You can gather lots of data about how the tooth fairy works, who gets how much money for what tooth at what age, etc. But fundamentally, you're investigating fantasy. This study, which I just thought was ludicrous, and I like to mention it, looked at the association between being yang deficient and outcomes on heart. And how do you know if you're yang deficient? You feel cold in your limbs, you're sensitive to cold, you're sensitive to cold weather, you're more sensitive to cold air, you have more flu-like symptoms than others, you worry about cold water or foods, and you have pulpy bowels after cold water or foods. That allegedly predicts response to antiretrovirals? No. Come on, guys. Tooth fairy science at its worst, or best, as the case may be. This is not available yet, but it's worth mentioning anyway for the treatment of HSV out of the New England Journal of Medicine, because there's a new agent that is effective at decreasing viral shedding of HIV. It's called pritelivir, Pritelivir, and it binds to the viral helicase primase enzyme complex, which is obvious if you ask me. And in a recent clinical trial in the New England Journal of Medicine, those who got this particular agent had decreased genital shedding of HSV and a decrease in the days of their HSV lesions, and it was dose dependent. This is a very early study, but it appears to be without toxicities, and we certainly need medications other than the acyclovir group for the treatment of herpes infections. Hopefully this will be released in the not-too-distant future when proven to be both safe and efficacious, and I'm sure, because it's the unique class of antibiotic, and given the history of costs these days with linezolid and fidaxomicin, that their 10-day course will cost a fortune. But somebody has to pay for the pizza at conference, right? There is a review of monkeypox in the Clinical Infectious Diseases this month. It presents like smallpox. It's in the same family of viruses and is found predominantly in Central Africa. I only mention it because it's probably going to be an up-and-coming disease in the future, because the smallpox vaccination also helped prevent the spread of monkeypox. And now we have an increasingly susceptible population to smallpox because we no longer vaccinate for it. It's now eradicated from the world. It gives the opportunity for monkeypox to spread and to be imported to the United States. And this will confuse you. It's called monkeypox because it was first described in lab monkeys, but it's often found in rats, mice, rabbits, and other rodents like prairie dogs. So don't think you get monkeypox from monkeys. You get monkeypox more likely from exposure to smaller vermin. I usually don't mention pediatric stuff because I don't do pediatrics for a living, but I just found this one of these curiosities, that if you get a full course of rotavirus vaccination, your chance of having a seizure requiring hospitalization or emergency care goes down by between 18 and 21%. An interesting potential benefit of the roto vaccine is to get less seizures. Go figure. Why might this be? Well, according to the article, quote, retrospective studies of first-time seizures occurring with a mild acute illness found that diarrhea or gastroenteritis was a common feature of illness in children with first-time seizures. So evidently, by getting rid of the diarrheal illness, you get rid of the seizures as well. What bug is going to be resistant first to every antibiotic? I'm putting my money on Neisseria gonorrhea. Not only, by the way, do the Swiss have spread of resistant HIV in their population, but this study from looking at gonorrhea resistance over a period of time from 1990 to 2012 shows that in Switzerland, both cefixime, ceftriaxone, and quinolone resistance has been going up steadily. So if you're going to Switzerland, don't have sex. Just concentrate on the mountains and the chocolate. One of the things that always amazes me as I go through the articles preparing for this podcast, and I literally, not figuratively, literally look at over 1,000 titles, is how many different journals there are. There's even a journal of lower genital tract disease. Who knew? And they looked at a meta-analysis as to whether or not the consumption of probiotics is beneficial in decreasing bacterial vaginosis. And the answer would appear yes. Consuming lactobacillus of a variety of types, acidophilus, ramosis, and fermentum, was associated with better results with bacterial vaginosis. The BK virus, the Burger King virus, is associated with hemorrhagic cystitis, and anytime you get an infection and a kidney transplant, you're more likely to reject your kidney. Cidofovir has been used for this virus, and the question is how efficacious is it, especially since it is a nephrotoxic antibiotic. This study was retrospective and looked at the response of BK viremia in patients with hemorrhagic cystitis who received cidofovir. And they found that patients who received cidofovir had a decrease in their BK viremia. They also had, in 9 of the patients of 32, had nephrotoxicity. And response to therapy may or may not have had something to do with survival, in that those who had a clinical response, 100% were alive, versus 73% of those who did not have a resolution of their hemorrhagic cystitis, although I'm certain that there were a lot of other comorbid issues in the patients who did not survive, besides the BK viremia. Hypermucoviscous. Sounds good. Or snot. This is what some isolates of Klebsiella pneumonia are. They make a big, thick, gooey capsule, and this is associated with liver abscesses. This has been an increasing problem in both China and Taiwan, as well as the United States, where it's becoming a common cause of liver abscess. But the good news out of China is that antimicrobial resistance in those strains is also increasing. The percentage of hypervirulent Klebsiella in China has doubled in the last several years, and 7%, for example, are meropenem resistant. And of course, being a Klebsiella, like being an E. coli, means it's going to rapidly spread across the world in the colons of human beings. I mean, to give you an idea, not only has it escaped China, but it's shown up in such backwaters as West Texas. Not that there are any West Texans who listen to this, are there? Have I just insulted some of my listener base? How to Win Friends and Influence People by Mark Crislip, MD. More on the wave of the future. Hypervirulent, antibiotic-resistant Enterobacteriaceae. It's the end of the world as I know it, and I feel fine. The classic association is between strep bovis bacteremia and bowel cancer. However, part of the problem is they further subspeciated strep bovises, strep bovi, strep bovium, I don't know. But anyway, one of them is now Streptococcus galactolyticus. And Streptococcus galactolyticus, for those of you who are keeping score, is a strep bovis biotype 1. This too is associated with underlying bowel cancer. not only colonic, but hepatobiliary. And about a quarter of patients in this article with Streptococcus galactolyticus bacteremia had an underlying gastrointestinal malignancy, and not just related to the colon, but upper GI malignancies as well. So galactolyticus in the blood should probably warrant a workup for underlying gastrointestinal malignancies. There was that fascinating article I talked about a while back where they used 16S ribosomal technology to show that the female bladder contained lots of bacteria that were not usually cultured. The same group has now done culture techniques on women without urinary tract infections and found that, yes, indeed, you will often grow bacteria in the bladder of women who are otherwise asymptomatic at very low levels. And that, contrary to popular belief, the urine contains communities of living bacteria that compromise a resident female urine microbiota. End of quote. My prediction, and I've said this before, is this now paves the way for urine transplants in patients with recurrent urinary tract infections. If the microbiota, of course, is beneficial in preventing symptomatic cystitis, and perhaps then antibiotics then mess up the local microbiota to increase the risk of getting symptomatic urinary tract infections. You heard it here first. Urinary transplants. I'm a genius. I just wish people would recognize it. As long as you're treating UTIs, by the way, appropriate antibiotic use with urinary tract infections in the hospital is a benefit. And those who get the right antibiotics have a decreased hospital stay. Isn't that amazing that if you treat somebody appropriately for an infection, they get better? And then I think what I will talk about more in my blog post at Science-Based Medicine this week is a study that used a Markov chain Monte Carlo model to look at the effectiveness of a variety of interventions in preventing urinary tract infections. And they found in this study that acupuncture and cranberry had efficacy. Interestingly, in the study, they gave acupuncture a 0.68 probability of acupuncture risk reduction in their model. My analysis over a long time over at Science-Based Medicine suggests that acupuncture is horseshit and that its risk reduction should be 0. This is a classic example, I think, of garbage in, garbage out. They also give cranberry risk reduction of 0.5, when most of the clinical trials would suggest that cranberry is not of benefit. The editorial that accompanies this, which is the most idiotic I've ever read in clinical infectious diseases, actually suggests that perhaps a patient would get cranberries and acupuncture to help mediate their recurrent urinary tract infections. That somehow the editors of the clinical infectious diseases think that somehow sticking needles in people once a month could possibly have some sort of physiologic effect to decrease the incidence of urinary tract infections. That is one of the most profoundly stupid things I've ever read in my flagship journal. When I first wrote that flagship, I accidentally substituted a T for the P. I wonder if that was a Freudian slip. This month, they discovered a new botulinum toxin. It's given the letter H. So we have botulinum H toxin. And botulinum H can also occur at the same time in an organism that makes the more traditional botulism toxins, i.e. botulism type B. The bummer about the type H botulism toxin is that we don't have any antitoxin for it. So if you should be unfortunate enough to get botulism with type H, you have no therapy to offer the patient. The other thing, which I keep wondering about with both botulinum toxin and tetanus toxin, is what is the role of those proteins in the real world? I just can't imagine that Clostridium has evolved botulinum toxin and tetanus toxin to kill us. It doesn't seem like a good way to perpetuate the species, and that these proteins must have some other function in the environment. I've looked multiple times to look for speculation as to why Clostridial species make these particular toxins, and I can't find anything. If there's smarter people out there than me, and there are a large number of them, I would appreciate having this particular gap in my knowledge filled. I have only seen one mycotic aneurysm from endocarditis this century, and it unfortunately ruptured late in the patient's course. This is a review of peripheral mycotic aneurysms and endocarditis in medicine, and it was, not unsurprisingly, uncommon, but interestingly, they treated them with surgical and or endovascular treatments with reasonably good outcomes, and that people who died were the people who died with just antibiotics. So the take home from this small series is that if you find a mycotic aneurysm with endocarditis, you should try to fix it anatomically besides giving antibiotics. The most recent meta-analysis, I'm afraid, shows that statins don't do anything to affect sepsis. This was published in PLOS One, which is kind of a bummer because it had looked encouraging. Then you have to contrast this with another study that showed in PLOS One that statins had an improvement in 14-day mortality, but not 30-day mortality for patients with staph sepsis who were on statins. And when you look at the article, their primary endpoint was 30-day mortality. And anytime, as the Zygris study proves, you try and make conclusions on secondary outcomes, and as a result of multiple analyses of various endpoints, you know it's probably garbage. I have really become a proponent of the Ionides article, why most of the medical literature is wrong. I always recommend that everybody memorize that article. And when you read an article such as this one about staph bacteremia and statins, all you can think of is, okay, probably not true. There are a variety of underlying problems that predispose people to chronic mucocutaneous candidiasis. This article in Clinical Infectious Diseases finds that one of the causes is an inherited interleukin-12 receptor beta-1 deficiency. This is one of a number of immunodeficiencies that have been associated with candidiasis of a variety of types. I see patients with recurrent candida not infrequently in the clinic, and it would be nice to be able to diagnose these patients and let them know what their immunologic issue might be. We are still not at the point in medicine where I can smear out everybody's DNA on a slide and tell them what their immunodeficiencies are. I look forward to that day. What's new in the mycobacterial world, you may ask? Well, I've certainly been seeing a lot of atypical mycobacterial infections of late. One article suggests that cellulitis in Australia may be due to Mycobacterium ulcerans, and it presents with signs and symptoms consistent with cellulitis, especially in patients with diabetes. So if you're in the land down under, think about Mycobacterium ulcerans as a cause of cellulitis. I think one of the big failings in infectious diseases is that we don't do blood levels. A lot of the times for drugs that are benign like beta-lactams, that's probably not important. And if you give enough, you can pretty much be assured that you're getting enough into the patient. Oral therapy is always problematic, and there have been studies to show with tuberculosis that low blood levels are associated with poor outcomes. No surprise there. Another study shows that the higher your rifampin levels are, the more likely you were to get drug toxicity from rifampin. So drug levels not only predict outcomes, but they can predict subsequent side effects with anti-tuberculous medications. Unfortunately, getting TB blood levels is not as simple as one would like. It can be done, but I really think that we underutilize blood levels for a lot of our therapies to both increase efficacy and hopefully decrease toxicity. And I love epidemiology. I've talked about how TB is spread between people and elephants. Now there's a report in medical microbiology and immunology where a zookeeper and his bonobos all developed tuberculosis, and it appears that the bonobos gave their keeper TB. So I guess that's it. The references are available online at edgydoc.com, where you can find links to my growing multimedia empire of blogs, apps, podcasts, books. And please go over to the Society for Science-Based Medicine, sfsbm.org, and check out our new organization. I promise you I will mention that rarely on this particular podcast because you're not here for pseudo-medicine, you're here for infectious diseases. But it is hopefully a worthwhile organization to occupy some of your time and yet another excuse to give me some money. Actually, it won't go to me, it will go to the organization. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.